Okay, so I hope you can all see my screen okay. And I'm just going to introduce myself a little bit. I'm Julian Cooper, one of the orthopaedic trauma surgeons at the Queen Elizabeth Hospital in Birmingham in the major trauma centre there. I've got special interest in pelvic and acetabular fractures, as well as a lot of lower limb trauma in particular, but trauma in general. I've worked there since about 2002 as a consultant. For the first 10 years or so, I was working solo as the only pelvic surgeon in the hospital. So I'm very glad now that I've got some more colleagues which to share the load. But it's something I really enjoy, and I'm going to share some of my experience with that there, particularly in relation to how we manage trauma early on in the process of dealing with these complicated injuries. First thing to say is that pelvic injuries fall into two main types: the pelvic ring injury and acetabular fractures. And I'm really only going to talk mainly about pelvic ring injuries tonight. I'll mention acetabular fractures only really to mention that the interest that I have in those is largely around the surgery that we do, the acute management, the early emergency department management of those doesn't tend to be quite so fraught as can be associated with pelvic ring injuries, which are often associated with bleeding, as I'm sure many of you are aware. And the interest with acetabular fractures lies in the sort of anatomical aspect of it, getting to it and operating on them to achieve a good result from the point of view of preventing things like osteoarthritis later on. I will just mention though dislocations, which are often associated with acetabular fractures, and it's very important that they're recognised and dealt with promptly, because dislocation of the hip is a very important emergency, and prompt reduction, even in the presence of an acetabular fracture, it really needs to happen very promptly indeed. But the bulk of what I'm talking about now is going to be about pelvic ring injuries. I first must emphasize that orthopedic trauma is a very small part of what happens with into the management of pelvic ring injuries. I depend very much on my colleagues in pre-hospital care, emergency medicine, and imaging particularly, but all these other specialties and more are often involved in the treatment of these, and I depend on those specialties to help me do what I do in terms of dealing with them. And even more, and this is within Birmingham, we have our major trauma service, which is key to coordinating between these specialties and between different injuries and different systems, as often in pelvic ring injuries that patients have injuries in other systems as well. And it's important to get the priorities right and coordination, making sure the right person's right place at the right time, right investigations are done at the right time, and that sort of thing. And we have this excellent major trauma service that helps us with that. Other major trauma centres will have their own systems for that, but ours is that special method, and we're very proud of that. So this is going to be an orthopedic trauma perspective on this multidisciplinary topic, and hopefully we'll give a bit of background about how bad pelvic ring injuries are and why they are bad, recognising which are the bad ones, and some handle on what to do about the bad ones, particularly in that early period after injury. Some helpful background, which is freely available. So many of you may be aware of the BOA, British Orthopaedic Association Standards for Trauma, the BOAST guidance or standards, which are very helpful in giving pointers to standard of care in these type of injuries, certainly in the UK, and the NICE guidance on complex fractures is very relevant to this. In many ways, unfortunately, it's not easy to achieve some of the ideals that are expressed in these, and for that reason it's very important to have people like myself and others who are able to provide advice to referring clinicians in other hospitals, maybe that trauma units, not major trauma centres, who want to refer injuries, so that we can give some good guidance on timing of transfer, on what type of management needs to take place. And we have in Birmingham a system called the NORSE system. The pelvic trauma NORSE is one of multiple NORSE systems for referring injuries and other conditions into the hospital. And in the pelvic trauma system, we're able to give a consultant response to queries about management, usually within 12 to 24 hours, often much quicker than that. And it's interesting, amongst all the injuries that we do see, we have maybe less than 10% need any form of intervention. But we do give that advice freely to help make sure that the patients get the overall management as effectively as possible. And the fact that only a small proportion of patients need active intervention is important to recognise that these, by and large, pelvic injuries are fragility fractures in terms of the overall injuries that we see, and very much a fracture of old age. This is the incidence of pelvic trauma by age. These are a few years old now, but the pattern is very similar. There's a peak in early adulthood, but then the incidence goes up pretty much exponentially through the rest of life as osteoporosis comes in, and elderly falls causing fragility fractures of the pelvis, mainly pubic rami fractures, occur. And this is a logarithmic scale, so you could barely see that bump in the young adult without that being on a logarithmic scale. But the injuries that tend to cause anxiety and worry in the emergency department, for example, the bleeding pelvises, tend to fall into this little bump at the bottom end here, although you can have more and more of these through longer periods of time as people are getting injured in older age groups, often on anticoagulants and bleeding in those circumstances. Just overlaid there the incidence of hip fractures, which are probably about getting on for 10 times as common as pelvic injuries. So what about these serious pelvic fractures, the ones that cause concern in the emergency department? Maybe if you're looking at TARN, the Trauma Audit Research Network returns, maybe 8% of cases returned from major trauma centres have a pelvic fracture. That equates to about over 6,000 pelvic injuries, serious pelvic injuries a year. We looked at our local referrals, and there's perhaps about 1 in 10,000 of our local population per year, 1 in 10,000 of our local population per year. Again, that would equate to a similar amount, about over 6,000 cases per year UK-wide. So the incident is fairly static. And we worry about them because they have a significant morbidity and mortality associated with them. Amongst patients who have a pelvic fracture, the mortality is higher than in non-pelvic trauma. Patients who have a pelvic fracture, if they're going to die, they die more quickly than patients who don't have a pelvic fracture. And all the indices of injury severity tend to be worse in patients with a pelvic fracture. So they're important injuries in that respect. And in understanding this, it's important to understand the background anatomy of the pelvis in relation to this. And we're asking that question, is the pelvis stable? And I should just explain, there are two main ways to look at stability here. There's often, we hear about hemodynamic stability and we hear about mechanical stability. And initially, I'm going to primarily talk about mechanical stability of the pelvis in relation to this. In other words, how likely is it during rehabilitation that the pelvis will stay where you want it effectively, how wobbly it is, in other words. And the pelvis is really a ring of bone and ligaments. You've got the main pelvic ring, two obturator rings, relatively weak ligaments at the front of the pubic symphysis. We have some much stronger, the strongest ligaments in the body, the sacroiliac ligaments, the anterior, interosseous and posterior ligaments there, which take a great deal of force to disrupt. And some secondary ligaments, the sacrospinous, sacrotuberous and iliolumbar ligament that act as secondary stabilizers of the pelvis that only really come into force when the pelvis is being disrupted in some other way. Their main job is actually keeping the spine stable in relation to the pelvis rather than the pelvis itself. If you imagine any brittle ring-shaped structure, when it breaks, it will tend to break in at least two places. So a bit like these mints, these ring-shaped mints here, they break in two places when you drop your packet of mints, and the pelvis is very similar. So if you can imagine the three ring structures, the obturator rings, the main pelvic ring. So if we have a fracture, say, through the pubic symphysis, then there must be, or very likely to be, an injury elsewhere. So, for example, the sacroiliac joint may be disrupted. Or if we have a fracture of the inferior ramus, it's likely the superior ramus will be fractured as well. And also, because that forms part of the main pelvic ring, there's likely to be an injury, say, to the sacrum or to the iliac wing or to the sacroiliac joint associated with that. So if we see pubic rami fractures, we need to look for an injury somewhere else in the pelvic ring, and don't settle until we've made sure that there isn't one, or there is one, whichever way you look at it. And this forms the basis of the commonest classification we tend to use for pelvic injuries. That's the sometimes called the Young-Burgess classification, but effectively a mechanistic classification of pelvic ring injuries. It's based on the direction of applied energy. And the premise is that the amount of energy that's applied and the mechanism will combine to produce the injury and the outcome, and to a degree, prognosis. We'll talk more of that in a bit. The commonest injury is probably the lateral compression injury, followed by a antero posterior compression and vertical shear injuries. I'll explain more in detail about how these injuries happen. It's the lateral compression injuries are the commonest one we see, and many of the elderly fragility fracture patients who fall from standing height onto their side will sustain a lateral compression injury with pubic rami fractures. And if you CT them, you'll see often that they've got an injury at the back of the pelvis, which would never have been appreciated in days gone by with plain film radiography. It's often fairly subtle, but there will be an injury somewhere else at the back of the pelvis, but they're usually fairly stable and able to mobilize. In higher energy mechanisms, lateral compression injuries are often associated with other injuries causing problems rather than the pelvic injury itself. Anteroposterior compression injuries have the most notorious reputation amongst pelvic injuries, along with vertical shear injuries, and they're both potentially highly unstable injuries, both mechanically and hemodynamically. So lateral compression injury occurs when force is applied from side to side. So common mechanisms would be falling from a standing height onto the side in fragility fractures, but somebody being T-boned in a car from the side with intrusion, again, from say their driver's door against the side of their pelvis, causing lateral compression of the pelvis that way. And this is a sort of 3D rendering of what that might look like. You've got pubic rami fractures anteriorly, and that continued movement of the pelvis inwards will cause a crumple fracture, an impacted fracture at the front of the sacrum, and that reduces the pelvic volume, and the fractures result in that. This fracture here is something somewhat at the more severe end of the spectrum. This is a patient who interesting enough, earlier in the day, she swallowed some coins and had visited the emergency department to get basically largely as an attention-seeking type approach. But when she was told that the coins would probably pass through, she was discharged and went home and decided that it would be a good idea to instead jump out of a window, and landed on her side. She wasn't shocked in terms of hemodynamic stability, but she was very wobbly in terms of the pelvis itself. That's the plain X-ray, and that's a 3D rendering of how her pelvis looked. And you can really appreciate how the pelvis has been squashed inwards by that landing from a great height onto the side of the pelvis. The iliac wing fracture there has allowed that to happen, along with these pubic rami fractures here. The first thing we did in terms of the orthopedic side of things was to put her on traction on her left leg. And it's interesting how the pelvis has kind of reinflated itself. And this, for me, is a very important slide, because it illustrates the key thing about lateral compression injuries, and that is that the soft tissues are generally less badly damaged than they are in an anteroposterior compression or vertical shear injury. And because when you pull on the bone, the intact soft tissues tend to stop any further displacement, and basically the pelvis can regain its normal shape, because those ligaments are generally intact, the pelvic floor is generally intact, and they were relaxed at the time of injury. And that's one of the reasons there's less bleeding generally associated with lateral compression injuries rather than the other types. So for this leg, so you can just see the coins appearing just at the top there, and further here on the post-op films that were coming through. For this lady, when we fixed her, because we wanted to be able to mobilize her. She's had percutaneous fixation there, open fixation of the crest, and the pubic symphysis plate going across into the pubic rami to stabilize that, to stop the pelvis collapsing inwards as she was walking. But that allows her then to rehabilitate effectively. So that's restored mechanical stability. Antero-posterior compression injuries, by comparison, occur in a different way. They generally cause with forces that applied front to back. So say falling from a great height onto your back, or more typically, it's something like a motorcyclist, for example, who hits something immovable. Their momentum carries them forward, so the front of the pelvis hits the tank, and the legs are forced apart, resulting in the front of the pelvis becoming separated, and those relatively weak pubic symphysis ligaments separate and allow the pelvis to start opening up. So at the first sort of stage, the first thing that happens is that just the pubic symphysis disrupts. There's minor opening of the pubic symphysis, generally up to about 20 millimeters or so. But the remainder of the ligaments are intact, so there's only so much elasticity, and that means that it won't open up any further than that as long as those ligaments are intact. However, if you carry on applying force with greater degrees of trauma, then you get to the next stage where the anterior ligaments of the sacroiliac joint have disrupted. The posterior ligaments have stayed intact. The symphysis is disrupted, and those secondary ligaments, sacrotuberous, sacrospinous, have also been disrupted. And the pelvic floor, which will have been under tension as a result, may well have torn in the process of this separation occurring. I'll also draw your attention to a small fracture there that's occurred in the L5 transverse process. And I'm sure many of you who's familiar with these type of injuries would have seen L5 transverse process fractures. And this is because the iliolumbar ligament, one of those secondary ligaments, avulses the tip of the L5 transverse process in many of these injuries, and is a useful indicator of severity of pelvic trauma. So this is moving on to the classic open book injury of the pelvis. And if we continue that force further, then the posterior ligaments will disrupt altogether. And that then effectively leaves the hemipelvis completely free with the lower limb attached to it. And then it becomes vertically as well as rotationally unstable. So at that point, the incidence of significant soft tissue damage is very high. Vertical shear injuries tend to occur more when somebody, say, jumped from a window, landed on one leg or landed on one buttock, and direct force is applied to the pelvis, pushing one side up rather than against the other. And these tend to look very much like the final stage of that APC injury we were looking at a moment ago. And again, intrinsically very unstable injuries. It's not common, but not unusual either, to have combined mechanisms. This is a patient from not so long ago that we treated who's got a combined lateral compression and APC injury. He was involved in a rollover type injury down an embankment into a ditch, had multiple injuries, including lung contusion, rib fractures, splenic tear, mesenteric tear, and a femoral fracture, as well as his pelvic ring injury. And he had this quite unusual combination of injuries, the iliac wing fracture, which is typically associated with a lateral compression mechanism, but also has got a divergent opening of that sacroiliac joint on the right, with a piece of bone that's embedded into the sacroiliac joint, which we had to fish out to fix the fracture. We've done a combination of percutaneous fixation and open fixation of the crest there to stabilize him, as well as fix his femur as well. So do these patterns predict hemorrhage and prognosis? Well, certainly the classic paper was from the Burgess of the Young and Burgess classification back in 1990, where he found that there was very high blood requirements associated with APC injuries and high mortality, as well as the combined injuries. And these patients tended to die from shock and from multiple organ failure type scenario. Whereas patients with lateral compression injuries required far fewer units of blood, lower mortality, and when they did die, they tend to die more from the head injuries and other associated injuries rather than the pelvic injury in itself. And this, it may perhaps not so clearly specific to the APC injury in subsequent papers, but generally speaking, vertically and rotationally unstable injuries tend to be far more of a concern in terms of shock and bleeding than the lateral compression injuries, reflecting what we were saying earlier on, that the pelvic floor is relaxed in the lateral compression injury and they tend to die from other injuries, whereas in the injuries that have the pelvic floor under tension and it tears, they tend to die from pelvic bleeding and other hemorrhage associated with organs within the pelvis. In terms of recognizing the difference on a CT scan, an APC2, where you've got the open book classic mechanism, you've got a bit of a hinge at the back where the posterior ligaments are still intact, and so you get this divergent opening, whereas the APC3, because there's complete disruption, there's parallel opening of that SI joint. And pelvic ring injuries are so dangerous in these subset that bleed, a small subset, it has to be said, it's still not very common even in the major trauma centers to see a significant degree of pelvic bleeding, but has to be watched out all the time. But the bleeding from the bone surfaces, disrupted vessels, and also because when these injuries happen, they tend to lose the natural structures that tend to contain bleeding. So there's a loss of natural tamponade. And if not corrected, coagulopathy of trauma will tend to compound the effect of bleeding. So this is an example of a patient who was involved as a record as a motorcyclist. He has got a parallel opening of his SI joint associated with an APC3 type injury. This is the CT scan on bony windows and here on soft tissue windows. And I'll outline the hematoma that's arising from the pelvis. So this is towards the head here, this is towards the feet in this direction. And the hematoma rises well above the level of the pelvis itself. And this will be extending into the retroperitoneum. And the reason this can happen is because the fascia around the pelvis is disrupted and allows that to, allows the bleeding not to be contained. And so it's been said that the bleeding escapes like smoke up a chimney. And in fact, it goes in the other direction as well. This is the source of the very large scrotal hematomas that are often seen swelling into the labia or bruising in the upper thighs that tends to come out after a little bit of time. But bleeding can go in both directions and be quite hidden unless, but needs to be appreciated just how much bleeding has occurred. And really, this gives the lie to the fact that you can't just control this bleeding just by reducing the pelvic volume, because the fascia will not be containing that hemorrhage simply by doing that. There needs to be something else as well. So how do we control pelvic bleeding? Well, the strategies available are, firstly, we can go through the natural process of looking after the primary clot that is formed at the time of injury and preserving that. Tamponade, but done surgically, controlling the bleeding vessel itself. Whoops. The first clot is that the patient forms is this primary clot. It's the best clot if you can keep that there, but it won't form if the pelvis is wobbling around a lot, and it won't form if the patient is coagulopathic. So the first strategy really has got to prevent the clot being dislodged and to make sure that the patient coagulation is maintained. So ill-judged methods of holding the pelvis, so this old-fashioned C-clamp that was nowhere near the actual bones, or an X-fix which has been placed inappropriately, will be wobbly and not controlling the pelvis effectively. And this is, again, why we don't now tend to log roll patients except for extreme circumstances in blunt trauma, because we don't want to dislodge clot, and we don't spring the pelvis to examine it because we don't want to dislodge clot in those circumstances. And in fact, now the paradigm is that most patients with appropriate mechanisms will have a pelvic binder already applied before they arrive in hospital. The pelvic binder, the most effective level is at the level of the greater trochanters, and that leaves the iliac crests clear for application of an external fixator if needed as the next step, because the binder can be kept in place while that X-fix is applied, or some other form of fixation. So the indications for a binder, well, pre-hospital is primarily around a suspicious mechanism. We've discussed the mechanisms already in the amount of energy that's required, but also for patients complaining of pain and whether you can get a handle on whether they've got a pelvic injury and maybe some tenderness around the pelvis, but not based on springing. In hospital, if somebody presents just because they have a pelvic fracture on a CT scan or whatever, doesn't mean to say a pelvic binder has to be applied. It really should be a response to a concern about ongoing bleeding or a patient in shock. A binder doesn't need to be applied purely because you have a mechanically unstable pelvis, but no element of shock. There are various designs of commercially available binder. You may be familiar with one or other of these, but it's perfectly possible to apply what you might call a do-it-yourself binder. And I tend to do a very similar thing to this when I'm operating on somebody, say I'm fixing a pubic symphysis. I'll apply a bandage around the thighs, around the calves there, over a bolster behind the knees, and that very effectively brings the pubic symphysis closer together, even without a sheet being wrapped around there. On this side, you can see the big scrotal hematoma that I was alluding to earlier on. Binder removal tends to cause some anxiety, but if the CT shows that the pelvis appears normal or that there's a stable fracture pattern, if there's no evidence of bleeding, then the binder can be removed almost immediately after the CT or initial imaging. But it's very important to realize that the CT scan can, on the CT, a binder can mask certain types of pelvic injury. And so it's important to do some form of imaging after removal of the binder to look for any hidden injury. If a CT shows a mechanically unstable fracture, then there needs to be a senior decision on whether the binder needs to be replaced by some other form of fixation or stabilization, or to remove it as soon as practical, because having binder on can lead to complications, as we'll see. So this is an example of one of the pitfalls that I was alluding to. So this is a patient who has a CT scan which looks essentially normal, but without the binder on, has got separation of the pubic symphysis, and that was completely hidden on the CT scan. The type of surface a patient is scanned on. This is a cadaveric study we did some time ago, where a patient with a simulated APC3 injury is on a scoop stretcher and being CT'd. Well, the cadaver's on the scoop stretcher, but if you scan the same cadaver on a flat board, then the whole thing opens up. And equally, just the scanning surface itself is concave, and that itself tends to reduce a pelvis. So you can be fooled just by the scanning surface itself. Do we know whether binders work? Well, that's a very good question. The evidence over the years is actually really rather poor quality. We do know very clearly from previous studies that they provide effective temporary stabilization, and there are some hemodynamic benefits, but it's not clear whether that's translated into improved mortality, reduction in critical care stay, and length of stay overall. Those outcomes are not clear, but it's a simple, fast, expedient solution to stabilizing the pelvis, keeping the pelvis still and keeping that clot stabilized. So again, removing the binder you should regard that binder as being a temporizing measure to get the patient to some other point, either to get the patient to angio or to theatre or wherever, or until it's clear the patient isn't bleeding and the binder can be removed, because you want to keep that binder on for less than 24 hours, preferably less, because of the side effects. So this is a patient who had a binder on for the best part of 24 hours. They've got skin ulceration under the binder. This is a patient who had a horse riding accident. She had a lateral compression mechanism injury, and her pelvis is windswept as a result of the binder being applied, because it's recreated the mechanism of injury. And removing that binder promptly allowed the pelvis to reinflate itself just under intra-abdominal pressure, and she was actually treated non-operatively, as it was stable enough to do that. But if it had been left in a position like this, then there'd have been unacceptable deformity. So we want to stabilize that pelvis early. We want to do things like instigate massive transfusion protocol, making sure that coagulation factors are given platelets. Tranexamic acid is essential in these circumstances. Simple measures like keeping the patient and the fluids warm. A question over whether Reboa, which I'll talk briefly about, although I've got very little, if any, experience of, but I'll touch on it. And then maybe surgical resuscitation, which I'll explain a little bit more about in just a moment. This is an example of a patient who had surgical resuscitation, 28-year-old man who was ejected from a vehicle, had a completely unstable pelvis and was in hypovolemic shock. On arrival, he was taken straight to theatre rather than going through a resuscitation room process. So he had quite aggressive surgical resuscitation, so aortic cross-clamping, ligation of the right internal iliac artery, pelvic packing. He had a whole blood transfusion because the austere environment in which he was in did not have access to clotting factors. He was then stabilized sufficiently by that to be able to, after a stormy course, have definitive fixation later on. Reboa is currently a subject of an interest in relation to controlling non-compressible hemorrhage. There's essentially for the pelvis would be zone 3, the infrarenal aorta, with a groin line put in and a balloon inflated in that infrarenal aorta to try and reduce the blood flow and reduce the hemorrhage as a result. Again, although we are part in Birmingham of a national trial of Reboa, as far as I'm aware, we've had only one attempt at treating a patient with Reboa in the context of pelvic trauma, and that had to be abandoned because of technical difficulties. So I think the jury's out on this in this country, although I know elsewhere it has been used to an extent, although it's by far and away not the most common method of trying to manage pelvic hemorrhage. So if the patient's not responding, where do we go from here? Well, it depends on factors like the availability of interventional radiology in your unit. Is it available locally to you, or in the actual unit itself, or by rapid transfer? Does the patient need to go to theatre for some other reasons, say they need a laparotomy for a ruptured spleen? And on the degree of hemodynamics compromise, because if a patient is so shocked that they're not going to survive a trip to angio for embolization or whatever, then clearly that's not an appropriate destination for them. Mentioned tamponade, you can only achieve that surgically in significant pelvic injuries by stabilizing the pelvis first and then packing the pelvis surgically from within. You can't just do it solely by reducing the pelvic volume. And remember those disrupted fascia that we were talking about. To do packing of the pelvis is it's actually a relatively straightforward thing to do, but many people are quite worried about the idea of doing that. Infraumbilical incision. Pretty immediately, with a patient with good going pelvic trauma, you'll come across the avulsion of the muscles from the top of the pubis, and you can follow the injury then down to either side of the bladder and put large packs in there. But it's important that the pelvis is stabilized first, with the minimum of being a binder around the pelvis to keep it in place, so there's something to pack against. That will then need to be, once the situation is under control, they're replaced by some other form of stabilization, for example, an external fixator. If this, another strategy is controlling the bleeding vessel itself. Now, it's not usually straightforward to get direct surgical control because there's a lot of bleeding around. You need somebody who can locate a vessel and ligate it, and that may require a vascular surgeon to be available, which you may not have. Indirect surgical control we kind of already touched upon as part of laparotomy or packing, but the one that generally speaking this refers to is angiography and embolization, so interventional radiology, but you have to have the facilities to do that. But I have to say that my colleagues in the interventional radiology department have kept my life far more tolerable than it would have been by their enthusiastic and very skilled interventional radiology skills, which control a significant proportion of the pelvic bleeding that we have. This is a patient, another motorcyclist involved in a collision with a car, came in shocked with a reduced conscious level because of the degree of hypervolemia, and had a pelvic binder in situ, been applied a little bit low, but is controlling the pelvis, vertically unstable, we can see here, so an APC3 injury. This CT scan, I'll just outline the hematoma, which is pushing the bladder across. It's quite an anterior hematoma with contrast blush within it. Angiogram was performed, and I'm always quite struck by how boring the hemorrhage appears on here. That just down there is the actual site of the hemorrhage, and that's really because the patients who survive to go, who are well enough to go to the angio suite, almost by default have a relatively slow bleed. Anybody with a much faster bleed would be self-selecting to more in extremis type of management requiring packing and the like. But that relatively slow bleed is still significant. One of the things that I was taught many years ago is that slow bleeding, though without replacement, 20 mils per minute for 2 hours will lose 50% of your blood volume. So effectively a lethal degree of blood loss. So these slow bleeds are important. And in this particular patient, he was embolized with coils here. That controlled his bleeding. The pelvis was stabilized with an external fixator, and traction was applied to the left femur to bring that pelvis down there. And he was kept like that until he was stable enough to have his definitive fixation a few days later. Iliosacral screw at the back and pubic symphysis fixation. So if there's no interventional radio on site, if you can recognize that this is a relatively slow bleed, then it may be possible to transfer your patient via hyperacute transfer to a centre with interventional radiology. But in extremis, it's going to be surgical control with laparotomy, with packing plus or minus laparotomy is needed. Where do we go after that? Well, I've mentioned external fixators already. Occasionally, an external fixator, when well applied, and the vast majority of military pelvic external fixators that were applied for blast injury in Afghanistan and Iraq that we came across were extremely well applied and could be used as the definitive fixation ongoing rather than needing any other form of replacement stabilization. But they can cause problems for definitive care. And many patients can't tolerate them very well, particularly if they're obese with the soft tissue aspects to it. And many trainees in orthopedics have not even applied an external fixator, so experience is important for that. What about acute internal fixation? Well, this requires certain skills. It's actually pretty straightforward putting a plate on a pubic symphysis if that's all that's required. And certainly if I was in a situation where I was involved in, say, somebody with a laparotomy who'd got a pelvic ring injury, it would be far quicker for me as a pelvic surgeon to put a 4-hole or 6-hole plate on the pubic symphysis than it would be to apply the external fixator. So I would do that, but not necessarily everybody would feel comfortable doing that. And occasionally it's possible to do more definitive fixation like an iliosacral screw. So this patient's had a screw put in percutaneously there at the same time as their external fixator was applied to provide extra stability. So overall, we've seen these are multidisciplinary injuries. And I'm going to mention just now some of the other subspecialty type injuries that cross over with the work that I do. I'm not going to go into all of them, but just some areas just to important to think about. Probably the one that occupies many people's minds is open pelvic fractures. These have a very variable presentation. Some are simple lacerations or injuries over the iliac crest and have a relatively mild as these go. But the really worrying ones are ones where you have open injuries into the perineum or occult injuries into the rectum or vagina. And these can be hidden and present later with sepsis. And so very vigilance for these sort of things need to be there. But the perineal injuries are usually very obvious and very dramatic. Multidisciplinary approach because of the structures that require reconstruction as part of them, but also to control the situation. So, for example, in the patient with a perineal injury, they may well require a diversion of the fecal stream to prevent contamination, as same with rectal injuries. So this is quite a dramatic picture, but it's a patient who, from a paper that we presented about blast injuries from military patients, showing the dramatic and awful scale of the type of blast injury that can occur. These patients had enormous blood requirements and a very high potential mortality. And we fortunately were, many of them, even though often had bilateral amputations associated with them, did eventually manage to mobilize despite quite dramatic pelvic ring injuries and their initial stormy course because of the degree of physiological upset. This is just an example of a patient with an open injury where there's been a rectal injury. Initially, this was missed, unfortunately, but these subtle little gas locules there should be the indicator that there is a potential for an open injury there. And these were from the rectum, had got out there, and that patient required diverting their fecal stream with a colostomy. Urological trauma is another source of some anxiety, particularly associated, should I pass a catheter or not? Bladder rupture and urethral injury, relatively common, certainly bladder rupture, but urethral injury is actually quite rare, but needs to be watched out for because of the consequence. There are some excellent, and there's a specific guidance from the BOA, again, jointly with the urological surgeons on how to manage these injuries. And I would encourage you to seek out that advice, freely available again from the BOA website. And essentially, a single gentle attempt at catheterization is permissible, even if there's a suggestion of urethral injury, and that was sanctioned by the urological surgeons. But that gives good guidance on what to do if you cannot pass a catheter, and how to investigate further and progress. I'll just mention again another source of confusion, which is spinal sacral injuries. Sacral injuries are quite common as part of a pelvic ring injury, but there are some sacral injuries that are actually more typically the spinal injuries, and these ones are the sort of U-shaped fractures, where you've got a transverse element going across the sacrum, and that allows the spine to flex forward within the pelvis. And these have got to be sought out very carefully. They're often not obvious on imaging, and the sort of techniques I have available to me to stabilize the pelvis will not stabilize these injuries adequately, and they will generally require neurosurgical or orthopedic spinal surgical stabilization from the pelvis to the spine with to help with that. So hopefully I've given you some indication of how bad these injuries are and why they are bad, and how to recognize some of the bad ones, particularly thinking about those vertically and rotationally unstable injuries, which have put the pelvic floor under tension, and the areas where we can do something to try and control that and modify the hemorrhage. I'd say the key messages you need to think about is understanding the mechanism of injury to help understand the injury, knowing what facilities you have in your unit to control hemorrhage and how to activate things like the massive transfusion protocol, but as well things like interventional radiology. Know about preserving the primary clot, simple and complicated measures to do that. And importantly, regard binders as a temporizing measure because they do have complications, and to remove or replace them with something more effective quite early on rather than leaving it a long time. Thank you very much.